Welcome to the HFMA podcast, the podcast for NHS finance. I'm Alex Hunt, Content and Social Media Executive for the HFMA. And today, I welcome back Steve Brown, editor of the HFMA magazine, Healthcare Finance, to discuss some of the biggest news stories from the past month. Welcome back to the show, Steve. It's been a few weeks since we last spoke. What are the big issues at the moment in the world of healthcare finance?
Hi, Alex. I guess there have been two really major issues occupying chief finance officers' minds of late: the requirement to cut running costs and pay awards. Let's look at those running costs first. Both integrated care boards and providers face a requirement to cut costs. For providers, this takes the form of cutting their corporate cost growth in half compared with pre-pandemic levels. According to NHS England, these corporate costs have risen by 40%, or 1.85 billion since 2018 and 19, or by 56% if pay and pensions are included. This reduction, half of the increase, needs to be delivered by the end of the third quarter of this year. That's Christmas. That's no easy feat. But it's arguably being overshadowed currently by the reductions required in ICBs. They too face a 50% cut. But for them, it's not just cutting growth, but actually halving their total running costs in programme pay, with the only things not counting against the ceiling being the costs associated with pharmacy, ophthalmic and dental services and specialised commissioning.
So how are they measuring the baseline? Is it 50% off everybody, no matter what their starting point?
That's a good question. Actually, instead of asking ICBs to demonstrate a 50% reduction on their specific current running costs, which would take no account of relative efficiency, the requirement has been translated into a running cost envelope of £18.76 per head of population, understood to be based roughly on a 50% cut at the aggregate level. There's considerable variation across ICBs, so some will face bigger challenges than others in meeting the target. And while there is some flexibility at ICB level, the target has to be delivered at the regional level.
50% sounds like a lot. How achievable is it?
Well, it comes on the back of 30% cuts in running costs that have already been delivered over the last couple of years. Some estimates suggest it means taking around 700 million out of current costs, but it could well be more. Again, it's the same timescale as for providers, delivered by the end of Q3, and then carrying that level of running costs into next year. However, ICBs were given an even tighter timetable in terms of setting out how they will achieve this reduction, with ICBs having to submit their plans for how these savings will be delivered by the end of last week. It really is a gargantuan task, and one that's arguably very distracting, given there's a huge agenda out there to reduce waiting times and start plotting the shift from acute to community and targeting more prevention. To realise the savings, ICBs have been encouraged to consider clustering arrangements as a first step towards merger, and reports suggest that the 42 current ICBs could reduce to around 28 under the plans submitted last week. To some, alongside the abolition of NHS England, this looks like the restructuring that all political parties set their face against on the grounds that reorganisations have a tendency to put the brakes on reform, at least initially. And the last thing the NHS needs at the moment is to get distracted from the transformation agenda. And the figure, a 50% cut, seems relatively arbitrary. It doesn't appear to have been informed by an analysis of the functions that ICBs need to carry out and best practice costs for delivering these. Instead, it appears to be an exercise in reverse engineering. This is the limit. Now make it work. It's not clear exactly what the 42 ICBs have put into those plans that have just been submitted, but they're unlikely to represent a finished position, with national moderation process due to kick in, which aims to ensure some consistency across the country and provide a chance to share good ideas and saving opportunities.
Have ICBs been given any help in deciding where to make these cuts?
Well, to an extent, ICBs have been operating in the dark in terms of what's expected of them. The broad direction of travel is that they should reposition themselves as strategic commissioners, less about managing contracts and more about shaping population health and outcomes, really tackling inequalities and driving those government shifts from acute to community, from treatment to prevention, and from analog to digital. But to help ICBs work out what they should be doing in the future, and importantly, what they should not be doing, NHS England has published a first draft of its Model Integrated Care Board Blueprint. This lists the things that ICBs over time should stop doing or do less of. Most high profile among the things that ICBs should stop doing is the oversight of provider performance in terms of finance, quality and operational performance. That will pass to regions who will assess providers using the NHS performance assessment framework. Although ICBs will still be expected to manage providers' performance against contracts, but there is a whole list of things that ICBs should be looking to drop or to transfer to other bodies. Emergency preparedness, resilience and response, workforce planning, sustainability, digital leadership, medicines optimization, and the development of neighbourhood and place-based partnerships. But there's also a long list of things that ICBs need to do more of and actually grow their activities. In population health management, now that's using data and analytics, predictive modelling, risk stratification to proactively improve outcomes. Health inequalities and inclusion expertise, the commissioning of neighbourhood health and of end-to-end pathways rather than just components of patients' treatment journeys. They're also expected to invest in core payer functions, really getting to grips with resource allocations and payment mechanisms. In fact, the guidance talks about ICBs investing in their understanding of costs and wider finance functions and developing capabilities in strategic purchasing, new commercial skills for innovative contracting and enhanced procurement skills. It means much greater use of program budgeting data, now relaunched as health expenditure benchmarking, which will enable systems to explore how much they're spending on different programs of care and compare this with outcomes to support better understanding of allocative efficiency. Could they get better overall value for money by spending their resources in a different way? I don't know, less on orthopedic and more on cardiovascular, for example. A common thread in all that is a lot more analysis of data to inform better commissioning. But it's hard to see how ICBs can realistically think about growing activities while they're faced with such significant cuts in running costs. To be honest, the timescale for submitting plans has been so tight that ICBs will still be spending the next few months working out exactly how they'll meet the cost targets their plans commit them to. It's unlikely that any ICB will have a granular plan at this point about how it will meet the £18.76 per head of population ceiling. There'll also be some different interpretations about what counts towards the target and what doesn't. Continuing healthcare as a service that gets mentioned a lot, but other areas of uncertainty include GP training hubs, patient transport advice centres and migrant health teams. All of this will no doubt come out in the promised national moderation process. But there are also a whole host of practical considerations. Redundancy is the big one. There have been suggestions that the Department of Health and Social Care or NHS England will cover redundancy costs for any staff ICBs have to lose. But some ICB leaders say they can't put schemes into practice without solid confirmation of how the costs would be covered. And redundancy, whether it's voluntary or compulsory, takes time. And so any savings on the pay bill are likely to be pushed into next year, which perhaps isn't an issue as long as there are no expectations about how these could help meet the costs of this year's pay awards, which we'll come back to shortly. There's also been no suggestion of any form of centrally ring-fenced pool for staff at risk, to keep redundancy costs down. There's a real concern, especially given the functions that ICBs are expected to grow over time, that the NHS could make people redundant in the short term, only to be looking to re-recruit to slightly different roles in the future. That wouldn't make any sense or represent value for money. Nobody's arguing that there is no potential to squeeze ICB running costs, or at least benchmark their costs and performance. But there is a good case for suggesting that at least some of the staff and running cost cuts will have a negative impact on how well systems can deliver on the transformation agenda. While clinicians are clearly the ones who deliver patient services, often it is those supporting the front line that help to address unwarranted variation or drive efficiency. And of course, not all of the staff cuts will be managers, but it's interesting to note that Lord Darcy, in his review last year of NHS performance, said that the problem in the NHS was not too many managers, but too few with the right skills and capabilities. And NHS spend on management is consistently below that of other systems.
The HFMA Members Summer Series is back, Following a record-breaking turnout in 2024, this free event is back for its third year, running online from the 17th to the 19th of June. Designed exclusively for HFMA members in bands 2 to 6, the 3-day online event brings colleagues together from across all 13 HFMA branches. Expect expert talks, career development insights, and networking opportunities with fellow finance professionals. Plus, with on-demand access for 3 months, you can catch up anytime. Don't miss out. Register yourself or your team today for free. Head to the link in our show notes to sign up. Back to the episode. That's a huge agenda, and we haven't really even touched on the parallel process going on in provider organizations. But what else is occupying managers, and in particular chief finance officers' minds at this moment?
Inevitably, it's money. As has been widely publicized, the first draft of finance plans for the current year suggested a 6.6 billion deficit across systems, ignoring formal deficit support. After a major financial reset, this was brought down to 2.5 billion, or a deficit of 300 million on top of 2.2 billion pounds of deficit support. And the latest position is that systems have now eliminated that headline deficit. So that means balanced plans supported by that 2.2 billion of deficit support. That was a major shift. But the plans that make up this improved forecast rely on some stretching efficiency targets, around 7% on average across systems, and a sizable step up on what was delivered last year. These will also have to be delivered with reduced or reducing staff, as corporate and running costs are cut in both providers and ICBs. But there's one further headache: pay. Allocations to ICBs assume a 2.8% increase for pay, but in fact the awards announced in May, 3.6% for Agenda for Change staff, 4% for consultants and GPs, and 5.4% on average for resident doctors, clearly outstrip this. And the clear message is that there is no extra funding coming from the Treasury to help meet these additional costs. Health and Social Care Secretary Wes Streeting has reassured NHS bodies that none of the pay increases will be paid for by cutting frontline services. He told the House of Commons that extra resources would be freed up to support the pay increases by cutting waste and duplication, through abolishing NHS England, and by reshaping and reducing ICB costs by 50%. And NHS England has very recently reinforced its message, saying that it expects the uplift to be funded. That's reassuring, but providers will want to see final confirmation that the full cost of the pay awards is being funded. They have too much experience from previous years of being expected to meet some of the pay award costs locally. Any sleight of hand that suggested that the savings from ICB running cost reductions or from providers' corporate costs could help make up the pay gap would not go down well. The NHS Confederation has estimated that it costs an extra 125 million a year currently for every extra 0.1% on pay for all staff groups, with a 0.8 percentage point gap between the government's pay assumption of 2.8% and the 3.6% awarded to nurses and other Agenda for Change staff. This becomes a very big number indeed. NHS providers has already called for assurance that the awards will be fully funded, worry that trusts can't take another financial hit through having to make up any shortfall in pay settlements. And hopefully NHS England's reassurances put this worry to bed. But to add to the risk on pay, there's no guarantee that staff and unions will accept the awards. So far, no staff groups appear to be too happy with what is on offer. There are widespread complaints about the differential value placed on doctors versus nurses, for example, and different staff groups highlighting how the awards go nowhere near far enough in addressing real terms reductions in pay over the last decade. Further industrial action would be a nightmare for the service, both in terms of progress in reducing waiting times and adding to those financial challenges.
This is clearly a very difficult year for the NHS in meeting demanding operational targets and living within its means. I mean, this would be hard enough, but with the required reduction in running costs, it is clearly even more difficult, and it will be interesting to see the details as they emerge of those ICB plans and how this pans out across the rest of the year. But Steve, thanks for joining us this week to break down the big news stories shaping NHS finance. As mentioned, Steve is the editor of Healthcare Finance, the official magazine of the HFMA. The magazine provides in-depth coverage of the financial challenges and developments affecting the NHS and the wider healthcare sector, offering expert analysis, insights, and best practice for finance professionals. The June edition of the magazine has just been published, and you can find the digital version on the HFMA website. For more news, articles, and blogs from the editorial team, visit the HFMA website to stay up to date with everything happening in healthcare finance. That's it for this week's episode of HFMA Talk. Thanks for listening. Don't forget to subscribe so you never miss an episode. And if you enjoyed the show, we'd really appreciate it if you left a 5-star rating on your favourite podcast platform. See you next time.